Welcome to our Integration Capstone project on finding patients with diabetes by Toyin Tagund, Sherry Lamoth, Grace Iriamiato, and Amber Berry. Today we will be talking about the Groovy Primary Care Clinic, challenges that occur in identifying patients with diabetes, errors in diabetic clinic data collection, and how these errors impact data collection for organizations. We will also discuss 4 solutions to reduce data collection errors. At Groovy Primary Care Clinic, 12 practicing physicians and a team of allied health professionals from a family health team offer primary care services, including access to family physicians, nurse practitioners, a travel clinic, and an after-hours walk-in. After reviewing the patients at the clinic who have diabetes to ensure they are receiving their quality follow-up visits, it has been noted that identifying which patient has diabetes is extremely difficult. Quarterly visits for diabetic patients are essential to ensure best practice guidelines are followed and that additional financial compensation is provided to physicians. After investigation, it has been determined that the challenges in proper identification of diabetic patients can be attributed to several key issues. The healthcare team uses forms in the electronic medical record to track patients with diabetes, but there are different versions of the forms from different organizations. Some physicians use a form from the family health team, while others use the form from the Ministry of Health and Long-Term Care, and others use a form created by the Local Health Integration Network. Some physicians do not use forms at all, and instead will add a note in the patient's diagnosis field. However, the terminology used to note the diagnosis varies from physician to physician and are recorded in many different and inconsistent variations. Today we're going to review this case and the data provided to make recommendations to the Groovy Primary Care Clinic to better identify and track patients who have diabetes. Let's get started. Diabetes is a common chronic condition that imposes a heavy burden of morbidity and early mortality on the affected patients and the healthcare system. Diabetes and its complications utilize a substantial portion of medical resources. At the same time, research findings now provide unprecedented levels of evidence regarding the prevention of diabetes complications. Identifying patients with diabetes is of the utmost importance to ensure proper education, treatment, and support for the patient, as well as accurate population-based data reporting. Data capturing for diabetic patients usually starts during patient registration through the collection of demographic information such as first and last name, date of birth, gender, address including the postal code, health card for billing, insurance coverage and medications, as well as medical history. The information is collected by the administrative clerk through an in-person questionnaire, or the patient is given a form to fill out and the information is recorded later. Recorded information is information that can be checked by any format such as paper and electronic records, digital photographs, videos, or maps. Accurate population-based assessment and data collection of the prevalence of diabetes becomes important for policymakers and those mounting and evaluating disease management strategies. Missing patient information by the clinician, an unknown family history, and or the absence of high-risk indicators from a patient may lead to incorrect or incomplete data coding. Patients are often screened using an algorithm that is looking for characteristics such as age, gender, body mass index, hypertension, history of cardiovascular disease or stroke, family history of diabetes, physical activity, work-related stress, and salty food preference. These characteristics are used by physicians as a predictor to screen patients for diabetes. Data is then coded and an algorithm applies this code to predict or identify those at risk of diabetes. While this data may be considered reliable, It may also contain errors as a result of how the data is collected. An analysis of clinical data found that not all patients were entered into databases. Therefore, not all patients were automatically detected in diabetes data collection methods. Missing patient information by the clinician, an unknown family history, and/or the absence of high-risk indicators from the patient may lead to incorrect or incomplete data coding. The impact of data error on organization and patient care cannot be overemphasized. In order for data to be of good quality, it must have 5 dimensions of quality data: relevance, accuracy and reliability, comparability and coherence, timeliness and punctuality, and accessibility. In a situation where all or any of these dimensions are missing, the result is data errors. These errors consequently impact the organization and patient care negatively. These negative impacts include, but are not limited to, increased financial cost, poor quality patient care, waste of time and effort, and lack of trust for the healthcare system. Data collection, capture, and receipt are used primarily for patient care and legal purposes. When there are errors, the organization can face legal implications. Additionally, patients will not receive quality care as the data collected is inaccurate. Data errors also divert resources away from other initiatives in order to correct the incorrect information. As well, the trust and confidence that the patients have in the organization may be jeopardized. The reputation will then need to be repaired. Accurate and consistent identification of patients with diabetes is an important part of the patient journey in order for them to receive safe and timely patient care. Understanding how many patients are seen at diabetic clinics, the reason for diabetic clinic visits, and the outcome of diabetic clinic visits will allow healthcare providers to provide more holistic and preventative diabetic care for their patients. This analysis will discuss how many clinic visits occur each month, reasons why patients are coming into the clinics, the outcomes of clinic visits, and the reasons for misidentification of the diabetic clinics. The next 4 slides will discuss the analysis that was completed for diabetic clinics. Organizations need to accurately document the number of appointments that occur at clinics. This allows them to determine the relevance of the clinic and also aids with funding. The total number of diabetic clinic visits for 2018 were 2,388. The month with the highest number of clinic visits was April, with 247 clinic visits. The month with the least number of clinic visits was January, with 137 clinic visits. The average number of diabetic clinic visits per month for 2018 was 199. The reason that patients are seen at clinics are important to know if the clinic is functioning the way it was intended and if patients are being referred appropriately. The most common presentation at the clinic was for a quarterly diabetic care visit, with this reason being 36% of all patient visits. The least common clinic visit was for a post-op hospitalization visit, which has documented as 3% of all patient visits. It is equally important for organizations to know what the outcomes associated with their clinics are. The total number of documented clinic outcomes was 2,081. The most common diabetic clinic outcome was for insulin education, which occurred 361 times. The least common diabetic clinic outcome was for referrals to an endocrinologist, and this occurred 318 times. Accurate identification of patients is necessary for patient care and timely care. There was a total of 9 reasons for misidentification of patients at diabetic clinics. The most common reason for misidentification, which occurred 204 times, was due to an unusual abbreviation used to document patients in a patient profile. The least common reason for misidentification of a diabetic patient occurred 25 times, and this was due to the patient profiles not being updated after the last clinic visit. At Groovy Primary Care Clinic, identifying patients with or suspected to have diabetes in the electronic medical record is essential to ensuring that the patient receives the follow-up and community support necessary to manage their disease while reducing the risk of harmful diabetes-related complications. The problem statement for the Groovy Primary Care Clinic is to improve the diagnosis data capture process to identify patients with diabetes 90% of the time. To address the issue of misidentification of diabetic patients, 4 possible resolutions are recommended. 2 of the proposed solutions are technical, and 2 are centered on improving the current human process that is already in place. The 2 proposed technical solutions are automatic prompt and an automatic redirect to confirm a diabetic diagnosis from the lab. The 2 human process solutions suggested are the implementation of a diabetic-specific care team and the creation of standardized forms that can be used for diabetic patients. These recommended solutions are ways in which the Groovy Primary Care Clinic can accomplish the goal of improving the diagnosis data capture process to identify patients with diabetes 90% of the time. A multidisciplinary team approach is critical to the success in diabetic care and the prevention of complications. The National Diabetes Education Program details how a team approach can facilitate diabetes management and can lower the risk for chronic diabetes complications. A dedicated diabetic care team would help educate patients about ways to reduce their risk factors for type 2 diabetes in family members. Additionally, care teams would ensure that each patient's chart is up to date and organized, and that the patient received the follow-up care required in the clinic and the community. The challenge with this model would be to broaden the delivery of care by expanding the healthcare team to include several types of healthcare professionals. Collaborative teams vary according to patient needs, patient load, organizational constraints, resources, clinical setting, geographic locations, and professional skills. In order to minimize and ultimately prevent the misidentification of diabetic patients, the use of standardized forms at diabetic clinics would ensure that all approved processes and identification criteria are followed by practitioners. Many of the errors from the data collected on diabetic patients occurred in the early identification and diabetic screening process. Screening criteria was noted to be inconsistent among clinic referrals, diabetic predictor factors, for example, high blood pressure, family history, and obesity. The data submitted was often misinterpreted by the clinician due to the inconsistent screening criteria. The use of the standardized forms would ensure that the criteria for referrals was consistent among practitioners, risk factors would be clearly identified, and that practitioners would be trained on the completion and interpretation of one form. This would minimize identification and interpretation errors. There are 4 different blood tests that can be used to confirm a diagnosis of diabetes. They are a fasting plasma glucose test, which measures blood glucose after 8 hours of abstinence from food, usually overnight. An oral glucose tolerance test, which is done when diabetes is suspected, but the fasting plasma glucose test result is normal. A hemoglobin A1C test, which is used to test the amount of glucose attached to the oxygen-carrying protein in blood cells. This test is used to diagnose type 2 diabetes and prediabetes. A random plasma blood glucose is the other test. To confirm a diabetes diagnosis, these test results must be repeated and confirmed on different days. An automatic redirect to confirm a diabetic diagnosis from the lab will instantly notify the provider when diabetic testing results are completed. The provider then must acknowledge the alert and either confirm or deny a diabetic diagnosis. A third option would be that an unknown diagnosis would lead to further testing by the provider. With proper care, it is possible for someone to live well with diabetes and avoid serious complications. Having hemoglobin A1C levels assessed every 3 months, including cholesterol, blood pressure, kidney function tests, and routine eye examinations are important as people with diabetes are prone to problems with their retinas and other important structures of the eye. If a patient is prescribed diabetic medications, a pop-up alert will prompt providers to identify that the patient is diabetic. This prompt will enable the provider to follow up with routine lab work, order additional tests, and make changes to the treatment plan. All of this information will automatically be saved to the patient's electronic health record and profile. The human process involves the collaboration of healthcare professionals, which enables the expertise of the professionals to be employed and used for the patient's optimal outcome. Additionally, the technicality of different tests carried out in the lab ensures that the treatment regime is adjusted to meet the patient's needs appropriately and complications due to lack of poor management of the disease is avoided. Therefore, when working together using a care team approach, it will minimize the patient's health risk through assessment, intervention, and surveillance, and will enhance the ability to identify problems early on and a timely treatment plan can be initiated. Proper and early diagnosis of diabetes is essential for patients to receive safe, quality, and appropriate care. Diabetes as a chronic disease is better managed with the approach of health team members, thereby preventing the complications that come with the disease as much as possible. The importance of early data capturing, analysis, and interpretation, and prompt action in finding patients with diabetes cannot be overemphasized. This concludes the end of our presentation.